So hello again and welcome back to this fourth session now of Rhythm Interventions Online. My name is Isabel Deisenhofer from the German Heart Center in Munich. And I'm really glad to have Julian Chung again back on the panel from Frankfurt. He's the head of the cardiology in the CCB in Frankfurt. And then newly on our panel is Andreas Metzner from Hamburg. Hello, Andreas.
Hello, Isabel.
He's the head of the interventional EP in the Hamburg University Heart Center. And again, Helmut Pürfellner from Austria, who is joining us from Linz. He's the head of EP in the Ordens Krankenhaus in Linz. So we are very glad to have you back again. And since we have a live case waiting for us, I will just hand over to our live case team in Arkansas. So Dr. Devi Nair from the St. Bernard's Clinic in Arkansas will guide us through this very interesting live case. And I hope that the team over there is ready to join us.
Hello, everyone. Welcome to the Nature State, Arkansas, and my lab in Jonesboro. Chris, can you put the slides up, please? We have a cryoballoon ablation with the Medtronic aortic fund system today that we would like to show you. What we're trying to do is reduce fluoroscopy, and that's been one of my pet peeves and one of my passions. So I hope I can do some justice today with the audience. First of all, I'd like to introduce my team. I have with me Justin, who's my scrub, Heath, who's a red tech. I have Andrea, who's our circulating nurse, Jeff, who's our monitoring person, and Roger, who's our CRNA. We also have Medtronic and our Insight mapping crew here that is helping us with the procedure. Can I have the next slide, Chris? So as I said, the goals for today is to discuss our protocols for same-day discharge that we do for majority of our cases, and to discuss my strategies that I use to complete a cryoablation with minimal fluoroscopy and sometimes no fluoroscopy. Next slide. Our patients most of the time present about 1 to 2 hours prior to the scheduled procedure. They usually come on uninterrupted oral anticoagulants. We have them take the last dose of anticoagulant the night before. We do not have them take it the morning of. All of our AF patients are done in the morning because we plan for the discharge later in the day if possible. We have the same pre and post procedural area that takes care of our patients when they come in and when they are after the procedure. So that helps with continuity of care. Our patients, when they arrive, are seen by the EP team, and on arrival, all the questions are answered and the discharge paperwork and discussions start at that point. Next slide. Our equipment is pretty straightforward. It's almost the same way, which allows for efficiency in the lab. The lab team knows very well how the case is gonna go, so they're almost always very well prepared. We get all of our access with ultrasound. We do a single transeptal approach, and we have 2 additional femoral sheets for intracardiac echo and for a decapolar catheter for pacing in the CS and in the SVC. Today, we'll be using a 28 millimeter AFA Pro balloon. You can see on the AFA Pro has a nose that's about 5.5 millimeters smaller than the AFA Pro, so hopefully we can get some good time to isolations because of that. And we routinely do not use contrast for our cryoablation. So we have a manifold setup. I have a picture up there. We have pressure, we have saline, and then the third is capped. We don't usually use contrast and use pressure monitoring to assess for pulmonary vein occlusion. And regardless of the size of the pulmonary vein, I start with a 28 millimeter balloon so I can get a wide antral ablation and use a 20 millimeter Achieve catheter. Now, routinely, we don't do cardiac CTs for our patients. Chris, can I have the next slide? So today's gentleman, he's a 71-year-old male with paroxysmal atrial fibrillation. His AF was detected on his cardiac device, and I put a snapshot of that in the corner there. He has been on flecainide and cardizem, and you'll see once we come on live, his heart rate's pretty low, and he continues to have documented self-terminated episodes despite being on drug therapy, and really would like to get off of his enterarrhythmics to avoid any kind of pacing therapy. He has a history of hypertension. He's on apixaban. His LA size is normal. He is about 110 kilos and about 6'2", which is average BMI for Arkansas. Chest CT was actually performed in this gentleman because of his complaints of chest pain. So I did use a CT, and we had it gated so we can show you an LA image. We don't routinely do chest CTs on our patients to avoid for radiation exposure for the patient, since our goal in the lab is to minimize radiation. Next slide. So we'll quickly go through the CT. You can see we are starting with the left common. You can see the right veins as well. There's a good ridge. There is a pretty decent carina between the right superior and the right inferior. You can see the appendage that does not have any thrombus in it as well. It's in the left bottom corner. We'll dig to the next slide. I did some measurements on the veins. That's the left common vein. And you can see my measurements are mostly showing what I consider the antrum. I'm not really measuring the ostium of the veins. I'm measuring the antrum there, and it's about 30 by 28. So we know that with the 28 millimeter cryo balloon, I am not going to be achieving occlusion in the left common. We are going to be aiming for a segmental approach in the left common. And let's go to the next slide, please. This is right superior, and that's two orthogonal views. You can see about 24 by 25. So we're hoping that we could potentially occlude that. And next slide. And this is the right inferior. So again, those measurements are really of the antrum rather than the ostium pulmonary veins. So Chris, can we focus on the axis here? So what we have set up so far is, as I told you, we have 3 venous sheets here in place. And as I said, all of our access is with ultrasound. We have a 10 French sheet that is 25 centimeters long that houses the intracardiac echo. We are using a St. Jude intracardiac echo today. We have an 8 French sheet that is housing our decapolar catheter. We have a Bison-Webster's decapolar catheter, and then we have an 8 French sheet that we're going to use for our transeptal. Why don't we go to the main screen so I can start with what we have on intracardiac echo. So we'll start with intracardiac echo. This is the home view. You can see as I'm rotating clockwise, here's the LA in plane. You can see the big left common. And then as I rotate further.
Just one question here, maybe from the panel. Do you, maybe I interrupted too early, but do you do then the exclusion of a left atrial thromboid only then during the procedure with the intracardiac echo, or do you perform anything pre-procedural to rule out?
Yep, so we, since we bring patients uninterrupted, we actually do it with just intracardiac echo. We'll actually go into the superior aspect of the tricuspid annulus and look at the appendage that way. And then we will, if we have to, we'll go into the PA. Once we go transeptal, sometimes I'll routinely put the intracardiac echo in the left atrium and look at the appendage as well.
Okay, perfect. Mm-hmm.
Oh, all right, so here we are with the left common. And then as I'm rotating clockwise, we can see the right inferior vein coming into view, and then the right superior vein at about 3 o'clock. So at this point, we're ready for getting ready for transeptal. So for that, I'm going to give an anterior tilt on that ice catheter. That's going to bring my SVC in view. And you can see my SVC is in view. The LA is at the top left. There's the pulmonary artery in its cross-section in the superior vena cava. So we're going to go up with the wire for my transeptal sheath. I use a standard SL0 sheath for my transeptal. And as I come up, we're going to be watching the wire. Now, if I have any trouble with the wire, I'll pull the ice back, and you can see my wire coming up and going into the SVC. And I'll confirm that by getting more of the SVC in view. You can see the wire just went up into the superior vena cava. So at this point, we're going to be coming up with our transeptal sheath.
Question to the,
this has been our,
the other on the panels. I have to confess I'm not using ice routinely. What is your routine? I don't know, Julian. Are you muted?
Very similar as like in Munich. We don't use ice. In Germany, ice is not that very well distributed that much. But I fully agree with the concept of trying to come down with fluoro exposure for a cryo procedure, because this was apparently one of the source of criticism, which also was detected in the fine ice trial. So I think it was more than 20 minutes fluoro exposure and not even thinking about the dosage. So therefore, I like the idea of coming down. But I have to say, I'm a little I'm not very familiar with the ice picture. I'm a little more familiar with the TEE, so I would have expected the wire on the other side. But I could see it.
So this is the inverse of the TEE. Yeah, this is your bicaval view, and you can see it's kind of the inverse. So you can actually see my sheath come up. So that's how I know my sheath is in the superior vena cava.
Yeah.
The superior vena cava is traversing from about 11 o'clock down to about 5 o'clock. And now we're going to come up. We use a Baylis needle for our transeptal. So this is an RF-guided needle. So I'm coming up with my Baylis system right now. So the needle is now in the sheath.
Maybe just a quick question for the panel. Does anybody use the Baylis needle, the RF needle? We use it in difficult cases, but very rarely. Is it a routine? Really? I mean, it's very elegant. So I have to confess, I'm watching carefully. But okay.
So you can see the Baylis needle enter kind of and the common vein there. It's very echogenic. You can see it doesn't push forward. Control transeptal, so I don't have to worry about the sheath kind of jumping forward, if I may, and then helps me move that transeptal sheath across. You can see I'm across on my transeptal at this point. We do our heparin pre-transeptal, so we've already given about 12,000 of heparin at this point. And we try to maintain ACTs at about 350. So at this point, I'm going to come to the view that is easier to see. Here's your left atrium with the transeptal sheath. To exchange to the flex sheath, I'm going to be putting up a Protract wire. This is also a Baylis product, so it kind of helps because it's a round, it's got a pigtail wire, so I don't have to kind of try to manipulate the wire into the left superior pulmonary vein. I go back and forth, dilate that transeptal, and you can see the Protract wire just kind of sits in the left atrium without much problems. So we're going to focus on the transeptal. Now we're coming up with the flex sheath.
Dr. Nair, one question, because you were able to nicely see and visualize the site of transeptal puncture for a cryo procedure. Do you have any recommendation for the audience where to puncture and or where not to puncture? What is your strategy on this?
So it's a great question. So I would say for a cryo procedure, staying a little more anterior or mid is probably ideal. I would avoid going posterior for sure, because I think you will have a difficult time engaging the veins from that angle. You can come as I would say as anterior as you want. I can tell you there are physicians that actually even go through the limbus, but I usually stick to the fossa.
Okay.
And
That's
here we're
interesting.
going to try to get the flex sheath in across right now.
Yeah, that's interesting. Apparently, there's many ways how to get to the final result, because at least in our Frankfurt experience, we are, I don't know, maybe it's not required, but we are trying to go for a mid or maybe posterior position in order to have, and we feel we have better contact, especially the right inferior PV, because of that axis site. Andreas, I don't know, what are you doing in Hamburg now?
I have to admit, I completely agree with you. So our preferred transeptal puncture site is usually as posterior as possible and as inferior as possible. And exactly due to the reason that you already explained, we want to be as close as possible to the orifice of the right inferior PV. Also to have enough mechanical stability, enough mechanical push given by the sheath and so on. So our target site is also posterior and inferior. Yes.
Yeah, I think one of the reasons I moved a little more mid is because of the concern of the losing transeptal while doing the right inferior. So I've kind of moved a little bit towards the mid position at this point. So we usually have a saline bag connected to our flex sheath. So at this point, we are ready to come in with the AFA Pro balloon. The balloon is prepped. Usually, as I said, we routinely try to do about 4 AF cases in the morning. So the staff is very, I mean, it truly is a team approach here. So they are very prepared for the case. They know what I want. So it's just very, you know, if we get thrown a curveball, that's different. But most of the time, the beauty of cryo is obviously the consistency and the simplicity of the procedure in some sense, if I may. So we are, you can see my cryo, the cryo balloon is in. I am using a mapping system today. We're using Insight to reduce fluoroscopy. You can see the chief catheter on the ice coming out into the mid of the left atrium. Can we gate it, please? So our Insight team is actually now gating for the respiratory gating the chief system, and we'll wait and we'll create a quick anatomical map.
Just as a question from my side, I did not see you use fluoroscopy. That's all of this was done so far, probably without any fluoroscopy, even the CS catheter positioning.
That's right. Yes.
Okay, and that's
So
one
we
of
are
these
moving.
great advantages of the Insight system, that you can really sort of show any visualize any catheter, and then really go ahead and place already this one without any fluoroscopy. I think that's really something I cherish a lot, and I love that nice beginning of the procedure. A second
I think
question
it's great to have an open-ended system.
Yeah. A second question, I mean, you're very, experienced with that, and you rely a lot on the ice. So you do not look for the the left atrial pressure. So it's not a pressure guided transeptal at all.
No, it's not a pressure guided. Where if I have trouble with the, with the transeptal for some reason, then I will definitely, to hook up pressure. But that's not a very common thing for me at all.
Yeah. Okay.
Can I have a PA view, please? So at this point, you can see it's a very quick anatomical map.
Yeah. And you're doing that with the spiral catheter inside the
yes,
that
exactly,
sticks out at the tip of the balloon. Yeah. Okay.
That's exactly right. So
Julian, is that something that you would do also in Frankfurt to have? I mean, that's also, as I said, it's quite elegant. I mean, of course, you have the double cost because you're using then the 3D additional to the cryo. But is it something that you did sometimes, or is it?
Yeah, I mean, we used to do remapping or mapping, creating a 3D shell with, for instance, using the laser balloon, and for some scientific questions. However, I have to admit, for a routine case in our hands, we try to really streamline it. And in this scenario, we would go single transeptal, balloon only, and
As a
no
PAV?
3D, no routine 3D mapping. However, of course, it may be of some help and may also be interesting in order to visualize the lesions afterwards. But it's not a routine scenario for us.
And Andreas, what is your approach?
As already mentioned, I think the beauty of the system is the simplicity and the reproducibility. And so we want to be as straight as possible. And so we, first of all, we do not use ice, as already mentioned, and we would also not go for 3D mapping. However, the conditions in Germany, as already explained by Julian Schoen, are different. So we have a fixed reimbursement. If we would add another 3D mapping system, the reimbursement would be less finally. And so actually, even if we would like to, we could not do that. We could not afford it. And for us, to be honest, it does not have that many benefits that we would think about using a 3D mapping system.
So we're going to start here. The balloon is actually in the vein now. And like I said, this left common is it's a big left common, and we're planning on a segmental approach. So we are not going to try to,
it could be of some benefit.
we're not going to try to occlude the vein here, but I'll go over our occlusion strategy. Right now, I have the chief catheter in the left superior aspect of the common vein, and you can see my chief catheter in there. The balloon's now actually in. You can see the tip of the sheath on ice. On the hemodynamic screen, what you're seeing is the LA pressure waveform.
Yeah. Dr. Nair, just a moment. Could I ask the tech team, could we see that intracardiac echo image a little bit larger? Because, I mean, it's the one where the things are happening now.
Yeah, I will do that. Sure. Can we go up on...
That would be great. I mean, we can see it,
but yes, please.
And we can see now on the, yeah, that's super. Okay.
So because this is going to be a segmental approach, we are not going to try to show you occlusion, but I'll do a couple freezes here, and then I'll go to the right and show the occlusion, how we assess occlusion. Now, the way I'm doing the segmental, I usually take it by quadrants. So right now, I'm starting at the inferior aspect, and I'm going to go inferior, and I've clocked my system, so I'm more inferior and posterior at this point. Let's come on freeze, please. I'm going to pull back the chief catheter so we can have some signals. This is a common, so it's going to be kind of hard to bring it back really quickly, and we're not going to see isolation because this is a common, but we're going to start our segmental freezes. Routinely for us, we do segmental freezes of 2 minutes each, and we have come on freeze at this point. So it's a truly anatomic-based segmental ablation, and what I'm seeing on ice in case of a left common. And that's one of the reasons we don't do CT ahead to decide whether we want to do a cryo or not. We truly use our cryo ablation for our true paroxysmal patients. So at this point, we are at, we're not going to get much temperature. We're going to do about, we're getting to about minus 30 at most, but we're going to do a 2-minute freeze here, and then we're going to move to another quadrant.
Can you steer the catheter additionally to the steerable sheath with the chief catheter? I mean, yeah, I saw that you had pushed it far into the vein to direct your balloon a little bit in the direction you want to go, additionally to the sheath guidance. So that's the two ways you can steer your balloon a little bit for that segmental approach.
Yeah, Chris, can you enlarge the ice image one more time, the ultrasound image? So you can see, I can see the sheath coaxiality to my balloon. On this one, I don't really have the sheath right behind my balloon, but you can see I'm on the inferior aspect of the common. And as I'm clocking, that's where you're going to see most of that balloon. Now, as I come anteriorly, you can see I don't see much of the balloon. Tells me I'm in the inferior posterior quadrant of my left common. So we are at about getting close to about 2-minute freeze. You can go back to the main screen now, Chris. Thank you.
May I also interrupt for a second and ask another question? I'm sorry, I like the way you're targeting those common OS. However, I just have the question, you mentioned that you usually apply 1 freeze per quadrant. How often does it really work? Because you also mentioned that you do not achieve that low temperatures, you only apply 120 seconds freeze cycle duration. So how often do you really isolate with 4 freezes?
I would say at least 80% of the time we'll get isolation with 4 freezes. If we don't, then we will actually map with the chief on the mapping system and figure out where we have the leak. And that's the advantage of having the mapping system. So now you can see on my ice, I actually just, can you mag up on the, Chris, can you mag up on the ice image again? Okay, so you can see on the ice image, my balloon is now more towards the superior aspect of the vein there. I'm going to move that again. And let's come up on the balloon, please. You can see now it's in the superior aspect. That's a superior posterior aspect now. Let's come on freeze here.
Can you show us the echo again bigger?
Yes, can we make the echo bigger, please? Yep. So that's, you can see the descending aorta, and you can see more of the balloon in that descending aorta view. So that's more posterior. And part of it is I have it pretty clocked. My flex sheath is at about 12 o'clock, noon position. So, and I've given up the curve of my flex. So I'm more in the superior posterior aspect of the left common at this point. I feel like for the comments, this gives me a much wide antral, I guess a wide antral lesion rather than, you know, a deeper lesion inside the main common.
Yeah.
What we'll usually do is we'll do 4 freezes.
How much effort or how much, let's say, effort do you spend on, again, watching the signals on your achieve catheter? Because, I mean, while ablating at the roof part or at the upper part, again, the same is true. You would expect a certain delay once you created a lesion, a line or an area of block at the upper part. And do you take that into your consideration once after having accomplished an upper lesion with your cryoballoon? Is it a strategy?
Yes, that's a great question.
Am I wrong?
That's a great question. So when we were doing the first lesion, we actually transiently lost the signal to 70 seconds. Obviously, they came back. So that was a sign for us that this is a good lesion. So if by 60 seconds I don't see any difference, then I won't continue that lesion. Now, in this case, you can see there is delay. You can see the Achieve 6 and Achieve 5 have shown some delay since we started. So that is why we're continuing on the lesion. We're at about 2 minutes now, and the balloon is currently thawing, and you can see that delay.
Yeah. Okay. Yeah.
So
now we
what
see
we'll
that
do
extra.
is we will do.
Yep.
Can we mag up on the? Yeah, not that one. Can we mag up on the intracardiac the electrograms, please? Chris, another one. Bottom right. There you go. You can see there's delay in the Achieve. It's especially Achieve 6 and Achieve 5 are showing you the PV signals that are delayed. And I think that's one of the things about the AFA Pro is even though this is a common, I'm able to pull that Achieve back, and that because that nose is so small, it helps me get the signals even when I'm doing such a big common. So now we're going to actually counterclock the sheath. Go. I'll try to show you a better image. We're going to counterclock the sheath.
Does the insight help you to determine which quadrant you are in, because you can maybe watch the Achieve in which position it is in relation to that common ostium? I mean that's maybe a helpful point where you can better guess in which part of the vein you are in the moment when you look at the position of the achieve in that in your the end-side mapping?
Yeah, so that's a great question. That's one of the, I think, disadvantages. You really can't assess the balloon position on InSight. You can kind of map with the chief if you don't isolate by 4 freezes. I can always map, but I don't use the InSight as such to decide where my balloon is. I usually use just intracardiac echo. And if we can enlarge the intracardiac echo one more time, please. Chris, can we enlarge the intracardiac echo? So here you can see now, this is posterior. So you don't see any of that balloon as much posteriorly anymore. And as I come anterior, I'm on the anterior superior aspect of that left common. And as I come a little more, you can see the mitral valve there coming into play so that you know I'm in the ridge. Again, this is usually one of the sites where I should see a good amount of delay or even isolation by this time. I will do one more freeze in the anterior inferior quadrant, and then whether we isolate or not, I actually will go to the right side. Mostly because I've done 4 freezes in the left side, and I want to stay away from the esophagus for a little while.
Okay, so you would stay then again 2 minutes, or would you increase the duration of the freeze?
So if for a segmental freeze, we stick to 2-minute freezes. Our dosing is, we guide the dosing based on 1 hour occlusion. We look at our native temperature. We look at how quickly we get to at least 30 degrees, and then or minus 30, and then we look at time to thaw. We also have, when we do the right veins, I'll show you how we assess occlusion. And there's some of the parameters on the occlusion that we decide, we actually take into consideration to decide the dosing strategy. So usually if we have time to isolation by 60, we go up to 180 for our freeze. And usually it's a single freeze if we meet all the criteria. Otherwise, we'll do a secondary freeze if I don't think I got a wider ostium.
Okay.
I mean, I have to say, congratulations that you really selected this case. This is a very challenging anatomy, I have to say, but you do a great job. Can I ask you regarding same-day discharge? Would you consider same-day discharge for balloon procedures only, or also, do you also perform same-day discharge with RF ablation? And how do you select patients for this program?
Balloon up, please. So I will, that's a great question. So we actually have been doing same-day discharges for a while. Let's go on freeze. Yeah. So we've been, sorry, I just had to get on freeze real quick. So we've been doing same-day discharges for a while now. And you can see the vein just isolated, by the way. So that was the last freeze before, just we're on the anterior inferior segment right now, and the vein just isolated. So we do same-day discharges. We've been doing it for about 3 to 4 years. I started off doing them with regular ablations or regular SVTs and stuff, and then started with cryo then. And then now I actually do same-day discharges for my RF ablations as well. Criteria for same-day discharge really depends on the comorbidities of the patients. If they have a lot of comorbidities, then we will look at their EF, their medications, their, how much help they have at home. If I'm particular that they have to have somebody at home with them if they are going home the same day. Jonesboro is a rural town, so we look at how close they are to a medical center. So if I want them, at least within a certain radius, if they're okay going home. But majority of our patients do want to go home, especially, with the pandemic in place, has given us much more motivation to send our patients home. And I think 80% of our patients go home. Even our appendage closure patients go home the same day. If the procedures are later in the day, then they stay the night. And what we do is we choose the higher risk patients for later in the day, so the lower risk patients can go home if they're scheduled in the morning. So at this point, while we are waiting, I'm going to actually take my decapolar catheter from the CS and move it to the superior vena cava.
I hate to interrupt you. We have, I think, a very interesting poll that I think you set up also the questions for, and that's exactly regarding the same-day discharge and this one AFib case in one day. Could we have the poll that Dr. Nair prepared? Otherwise, I'm reading it to you.
So that's great. So you can actually see my decapolar catheter in the superior vena cava on intracardiac echo.
Yeah, just a second. I'm just going to read that question because I think it's very interesting. So the question was, what is the primary concern about same-day discharge for AF patients at your center? And A would be the procedure is too complicated, concerns for complication. The B would be the team is not comfortable with the same-day discharge. So I don't know, people don't feel too well with that. Patients prefer staying at the hospital. That's, in my experience, something that might happen a lot of times. And then there's this use for general anesthesia or late procedure completion time. So in contrast to how you set up your clinic, Dr. Nair, so cases done in the afternoon or even the early evening. And I think that's a very interesting poll, and we are eager to see the result of that poll. And we have an additional question in the chat that is referring to the 30-day complication rate. If you see anything, any signal that tells you that in some of these patients, maybe that one case, to do that AFib case in one day leads to an increased 30-day complication rate regarding, for example, late groin bleeding or something like that. Do you have any statistics about that?
So we are actually formally looking at our stats right now. We have done pretty well with it because we actually started this as a pilot program, so we had to make sure that we were okay before we went full force on our, I would say, same-day discharge. So we had to collect some quality metrics before we got okay from truly the hospital in a sense. Hold on. So I want to just, can we enlarge the ice image while we're here? So you can see I'm showing you the right inferior pulmonary vein there. You can see my sheath is in there. My achieved catheter is actually in the inferior branch of the pulmonary vein. And I'm actually moving you can see the balloon coming out. So one of the beautiful things is I don't have to, hold this right here, please. Hold on. So we're going to come up on the balloon here. Balloon down. So let's go back to the main screen. So I want to focus on how we get pressure occlusion. Focus. Don't worry about that. So can we enlarge the hemodynamics there, please? So you're seeing the LA waveform right now, right hand. There you go. Hold this right there. Okay. So we're going to come up on the balloon here. The balloon is up now. And when we have occlusion, you will see the pressure waveforms change. And so the advantage of that is that you can see the pressure waveform just changed. So that is the way that we assess for pulmonary vein occlusion here. So it is a real-time occlusion.
So it basically
and so
looks
I'm not really moving
like a wedge pressure in a coronary artery,
yes.
no?
Yes.
A little bit like that.
So so we are not using contrast. We're doing this for our occlusion technique. So our chief catheter is a little bit on the outside.
As I'm not a cryoballoonist, I have to refer to Andreas Metzner and you, Yongi, and maybe Helmut. Could you tell me, is that something that is attractive for you, or what's your clinical practice?
Maybe I just start. I think it's an elegant way on how to judge whether the PV is isolated or not. But I also have to admit that at our center, we still rely on occlusion angiographies. So whenever we want to test for occlusion or not, we inject contrast and just check whether it stays or not. So I don't have any personal experience with this wedge pressure measurements. However, I think it's an elegant way to further reduce fluoroscopy time and fluoroscopy exposure, no question.
So I want to actually show you something on intracardiac echo. Can we indulge the intracardiac echo? Can we come off pulse wave? So the way we assess phrenic is we not only just feel the phrenic, you can see the liver with the liver capsule. We're going to actually pulse wave Doppler our liver capsule. Gracie, can we go on pulse wave? So we're actually pulse wave Dopplering, and you can actually get a quantified. So this is your CMAP from intracardiac echo, and I think you're not affected by the BMI, which is a big issue in Arkansas. So we like this for our assessment of phrenic. It's a very quantitative way of assessing phrenic nerve function for us. And the vein actually has isolated, by the way, and we are going to continue our freeze to about 180 since we had isolation before 60 seconds.
Yeah. Again,
we isolated at about 42 seconds.
Yeah, again, very elegant, because this is like use everything you have from that one ICE catheter.
So I think you have to. So I think that there's always the question that comes about cost. You know, the ICE obviously adds to the cost, the mapping adds to the cost of the procedure. And I think that has always been one of the questions that have come up. But for me, I feel like the safety from a radiation standpoint for the patient, for the entire lab team, the fact that none of us are actually wearing lead. We don't wear lead for any of our ablations in this lab. So it's a big occupational benefit to be in the P lab from that standpoint. So I feel like a long time ago we would have people go away from the P lab because of the long cases that we used to do in lead, but we have come to a point where we're actually not wearing lead at all. So it's really more fun now. And then the mapping, obviously, I think it adds a lot of value. And because we're able to do these cases efficiently, you can stop pacing. We are, you know, we have had to show the hospital I guess the financial benefit of being able to use all these adjunct measures. And it adds to the safety of the procedure for us. So I think that is a very, you know, very big deal for us. So I want to focus on the hemodynamics here. Let's come on. So this is one of the other measures. You can see as we're thawing, I came back with that occluded waveform. So that tells me that my balloon didn't move. And then as the balloon deflates, you can see we go back into the LA waveform. So that tells me, that's another way for me to know that, you know, that this is another factor that tells me whether I'm going to continue, give another freeze or not. In this case, we had great time to isolation. We had a great thaw time. We had a great occlusion, not just starting, but also as we came on thaw. So these are going to be the factors, and you can see an isolated signal that just came through. So we're going to come out of the right inferior at this point. Inflate, deflate.
Just to
and we're going to move into the, you can see the balloon there.
Dr. Neer, we have the results of the poll now, and I think it's very interesting. The answer to that question was, what is the primary concern about same-day discharge? 41%, so a slight majority of the people watching us said that the procedure is too complicated and that they have concerns for complications. And I think you very elegantly just right now showed us how you can sort of simplify that procedure and really get it back to a stage where we see, okay, you have this step that is less complicated than the other one. So I think that is something we have to get back again and rethink. Team is not comfortable with the same-day discharge. I would have said that's the least concern, and that's how it feels. Patients prefer to stay in the hospital, okay. And then I think what is a very important point, at least in our center, is that we have these late procedure completion time, so that we finish these cases only in the evening, and that we are a little bit afraid to discharge these patients 1 hour, 1.5 hour after the procedure, so not watching them anymore. So what is the feeling of the rest of the panel? Helmut, what would you feel about the same day discharge, and what would be your primary concerns?
Well, two points. First is on same day discharge. I think it's feasible. I think the way she proposes, Dr. Nair proposes, is a good way, especially if you do a cryoballoon approach with all the precautions that she uses, and you take the patients in the morning into the lab. So no problem with that. I personally do not do that. I have at least one night after the procedure to see the patients next day, to talk to them, and they also want to know how it went. And you know, they are quite tired, sleepy after the cedar analgesia that I give. So on the same day, that would be difficult. However, I have a question, maybe a provocative question to Dr. Nair, and that is, you know, you're not using any fluoro, you're not using any contrast. That's good. However, you're using CT beforehand. So the patient gets fluoro, the patient gets contrast. And my question is, why do you use a CT? If you have everything you show us today, what is the sense of a VT, of a CT?
That's a great question, and I started with that. So we don't routinely do CTs. I actually don't have CT images when I start for 99% of my cases. This patient had a CT done for chest pain way before this, so we actually just used the gating and just created the LA map just because we knew we were coming for this case. And then it's more fun to bring a left common to a live case. So there you go.
Congratulations, you did it super.
So we are actually,
You have a question.
we're
Go
actually
ahead.
on our right superior. We're on
You
our
have
right
to
superior
interrupt,
freeze. I just want to give you an update. We are at 180 seconds of freeze. We are isolated, and we're going to be coming off at this point. And we're going to enlarge on that hemodynamics again, Chris. So you can see the beauty about the hemodynamics. You know, I understand the use of contrast very much, and I think there's great value to it. But for me, the beauty of the pressure monitoring system is, number one, you can avoid contrast. Number two, you avoid fluoroscopy. Number three, you're getting your occlusion real time. So as I move my sheath and as I move my balloon, I see the waveform change. I know I'm occluded. I'm not moving, the puffing and moving and puffing. So I think that's a good advantage. And I don't think you can assess what I get to see now, which is I'm thawing the balloon, and as the lumen opens up, I'm going to see my pressure waveform come back. And if I see that it comes back occluded, it's an added advantage, especially, you know, we know there's a little bit of the balloon could move as we're freezing. I'm pacing on the phrenic, so there's a little bit of jump to that. So if I see that the balloon comes back occluded, then I think it's a good thing for me. Now, in this case, the right superior isolated under 20 seconds, so I'm not as worried about it. And the one thing I want to show on the ice as well is the fact that I'm actually ostial on the balloon rather than deep in the vein. So that's one of the other ways I know I'm ostial. So at this point, we are really getting ready to do a post map because we've isolated all of our veins. And I mean, really quick map, nothing much, but otherwise we're finished with our cryo case at this point. So that's, we're just kind of quickly mapping. Here's the right inferior isolated. Here's the right superior. I'm actually on the map right now. Can we enlarge the map, please? Thank you. So I'm quickly moving. The one is an anterior view, one's a PA view. We're going to be coming back to the left common here. The left inferior is isolated. We had clear double potentials before. Why don't we pace achieve 4? We'll just show exit block just to make sure that we're not at 600 at 8 milliamps, please. So we had clear double potentials before. And on the inside, you can see the unipolar recording that's gonna, you can see there's exit block, stop pacing. And then the unipolar recordings clearly show me that it's not a Q wave, it's mostly R. So that's another way. So I'm gonna pull it up to the ostium. We can go back to the main screen if we need to. So the superior aspect is also isolated. There's a superior aspect, which is also isolated. The signals we're seeing are mostly in the appendage area. It's mostly a clearly demarcated signal. It's a pretty wide isolation. I'm going to bring that down. Marcus, can I see the bottom aspect, please? And if we can go to the ICE image. You can see on ICE, I'm mostly using just the achieve, kind of moving around, getting an idea where I am with my catheter that helps me figure out if I'm too deep or not so deep. So at this point, we are kind of done with the left side. We're going to be coming back. We actually reverse for our cases. We're giving about 50 milligrams of protamine. I want to come focus on the groin here. Let's get some post-ice images. So we are right now on the right side.
Okay.
So
you mentioned before
we have
that you
figure of 8 sutures here.
You mentioned before you have the 3 punctures, I believe, in the groin, which we can see nicely
That's
now.
right.
And all these
Yep.
punctures are done under ultrasound guidance to be sure that you don't have any problems created by the puncture, but really are truly have a venous access only without any problems. Do you have sort of a feeling for how much this use of the ultrasound for the puncture in the groin did reduce your groin complication rate?
So my fingers crossed. We've not had a groin complication in the last 5 years since we completely switched to ultrasound. And this is one of those comfort features that lets me let the patient go home the same day because I'm not really worried about that part. And you can see what I'm doing is a figure of 8 suture with what I have is a stopcock that's up there. So that's our routine. I actually do a double stopcock method. So here the sheets are coming out. That looks pretty good there. So you can see I have a second figure of 8 on the top there. And because I'm in the same groin, I like to have a second suture ahead of it just to give it a little more traction for the tract. So right now I have 2 sutures, especially most of our AFib patients are under general. So as they wake up and they start coughing, sometimes the single figure of 8 never holds. So we actually now use a double figure of 8 there. So one's actually on the entrance and one is a little bit higher on the tract as such. So so at this point we're done. We have reversed the heparin. And
so you do not have any compression on that groin. It just you leave the 2 figure of 8
yep.
sutures, and you have the reversal of the heparin. Any dosage that is dependent on the weight, or how do you give your protamine? Is that depending on the dosage of the heparin, or is it a standard or ACT driven? Or?
So it's not really ACT. We almost always achieve an ACT above 350 with our heparin, and if we keep our ACTs between 350 and 400, then I routinely give 50, which is kind of, I would say 99% of my AF cases get about 50 of protamine, mostly because we are just using a figure of 8. Now you said I just put the figure of 8, I'm not holding pressure, but obviously we're gonna stand here and as the patient wakes up, if the patient coughs or something, we'll definitely hold a little bit of pressure. If the patient's coughing, or we will readjust the sutures. And I think the thing about the suture and the stopcock for me is, I have the patient down for, say, 4 hours. Before we take the sutures out, we'll actually come back on the suture, we'll loosen it. We'll just leave the suture there and then let the patient ambulate. If the patient's good for an hour or 2 with ambulation, then we take the sutures out. Say if the patient has any kind of recurrent bleeding, we'll just go back and tighten the sutures back up so we're not at that point struggling. We used to do ties, but we stopped with that, and we kind of use this at this point.
Yeah, I think it's a
Very
very
elegant.
elegant
I like
way
it.
to keep the patient under watch and still have the possibility to even readjust the suture if you find out that it's not sufficient. Any comments from the panel? Yeah, you, Julian.
I mean, congratulations, great case, very challenging case, and perfect timing. So you did a very good job. However, very much like Helmut was indicating, I like, in principle, very much the idea of same-day discharge. However, I think this the message also should be clear. You're very experienced. You have an experienced environment. So, and we know from recent data from the United States, American data, that the complexity of AF cases is increasing, and thereby also the chance for complications. And I think this is therefore, with regards to patient safety and patient selection, it's still a word of caution from my side. I think not everyone is maybe suitable to do a same-day discharge for every patient, so therefore we need to be careful on this.
I totally agree. I think, it took us a year to kind of get our protocol in place. I think you have to have a real good team in place that understands the importance and the safety aspects of it. So I don't think anyone should jump into same-day discharges. I think it's a slow process. I think you carefully select the patients that you start off with and slowly advance to the more complex procedures like AFib and such. And again, I think it's important. I mean, there is same-day discharge, but then there's also, the patient satisfaction matters too. We do everything for the quality of life of the patient. So it all really comes down to how comfortable you were with the procedure. Even though my patients know they can go home the same day, if I tell them, no, I think I want to watch you longer, they are completely fine with it. So I think being realistic about the procedure is important.
That's a very good point in the end, and I think I thank you, Dr. Neer, and all the team at your hospital. I think you did a tremendous job. That was a great demonstration of how you can really very elegantly streamline that procedure. And maybe we can conclude that in these patients, when you have this kind of setup in selected patients, it's probably a very good thing to do. And you have to keep in mind, as Julian said, that it's a patient selection. And I think it's also a center experience that has to be built then to do this safely. So thank you, all of you. Thank you to the panel. We have to move on, and I'm very glad to have been chair of this really nice procedure and nice session. And see you soon. And there is the continuation with session 5 now. And I hand over to Dr. Schilling, who will be the chair for the next session. Thank you so much.
Hello and welcome back to the Rio Control Centre in London. You'll notice I'm wearing a mask, and the reason for that is that we have a very special guest who's been standing here patiently for the last 15 minutes. So Nick, you've had your ablation and you're on your way home.
Yeah.
How did it feel? What was the experience like?
Yeah, it was really smooth. It was non-traumatic, really smooth from the beginning I got here till obviously now.
Yeah.
How long have I been here? A few hours. And on the way home. So
great.
Yeah, it's fine.
Well, look, I'm really, because Nick threatened to pretend to faint when we were live on screen, so I'm very grateful you haven't done that. Thanks very much for being a great sport, and I will give you a call later on and make sure you're okay.
There we are.
And have a great evening.
Yeah, you too. Thank you so much.
Take care, mate.
Thank you.
All right. See you later.